que se llama la siguiente mesa Futuro en Transfusión Prehospitalaria, sangre completa. Va a moderar el doctor Ricardo Valle, médico GUETS de la Gerencia SESCAM, médico en la UME de Puerto Llano y en el helicóptero sanitario Gigante 2 de Ciudad Real. Tiene la palabra el doctor Valle.
Bueno, para terminar, y perdóname que aparezca otra vez por aquí, bueno, hemos estado hablando hoy, se ha nombrado en varias ocasiones y al doctor Yazer, Mark Yazer es un hematólogo que trabaja en Estados Unidos, en Pittsburgh, que tengo que coger para ver el currículum porque es impresionante. Bueno, Mark es profesor de patología en la Universidad de Pittsburgh, es profesor en la Universidad de Tel Aviv, es profesor de inmunología en el Southern Denmark, el sur de Dinamarca. Participa también como profesor asociado en Brasil, en Sao Paulo, y trabaja para las Naciones Unidas como asesor experto en hemoterapia y transfusión prehospitalaria. O sea, yo creo que por eso tiene tantos papers, por eso tanto se ha nombrado hoy y por qué no vamos a dejar de hablar nosotros y vamos a escuchar a lo que tiene que decirnos Mark Yazer, ¿vale? Que tenemos una oportunidad estupenda y, bueno, creo que nos va a aportar bastante, ¿vale? Mark. Hello, Mark. Are you there?
I'm here. Is this being translated now?
Okay, you can start when you want.
Okay. Muchas gracias, everyone. Is this being translated now?
Yeah, it's okay. I think so. Yes, it's okay. You can carry on.
Okay. Well, what a pleasure to be invited to this important meeting to introduce pre-hospital transfusion and whole blood transfusion into Spain. As you know, my good friend and colleague, the previous speaker, Jose, has been a very important person in implementing low titer Grupo whole blood in Spain, and I watched his presentation, and there's going to be some of the same things said in mine, but hopefully it will be sufficiently different that you'll be able to appreciate both of our presentations. So once again, Ricardo, muchas gracias for inviting me, and I hope that my presentation and Jose's are different enough. So here are some disclosures that I'm required to tell you about as we look over my city of Pittsburgh. It's called the City of Bridges because we have more than 400 bridges in the city, and you can see it's very pretty. So, you know, I think the whole day we've been talking about whole blood and what it is, and I think my assignment here was to remind you about the benefits of using whole blood, in addition to what Jose was telling you about before. As you know, whole blood is everything that comes out of the arm of the blood donor. We add 70 milliliters of anticoagulant and red cell food, and we can keep it for 21 or 35 days, depending upon the solution into which the whole blood is collected. I think I heard some discussion about leukoreduction during the panel session before. I don't know what the answer was, but my opinion is that if you are required to do leukoreduction because of the law, then that is fine. It probably does not damage the platelets. On the other hand, if you are not required to do leukoreduction, that's also fine, because the benefits of leukoreduction are typically only for those patients who are stable and who will require multiple transfusions over time, like hematology patients. There is not evidence to show that that trauma patients benefit from leukoreduction. So whether you do leukoreduction or not, it should not affect your ability to implement a whole blood program. There are two kinds of whole blood. There's the warm, fresh blood that we've heard about earlier, no doubt. That is not an FDA approved product. What we use in the US is cold stored whole blood, blood that has been collected from approved donors and fully tested and shown to have a low antibody titer before we issue it. And this will be the type of whole blood that we talk about today, this cold stored whole blood, not the warm, fresh battlefield transfusion that the military can use. So what are the benefits of using whole blood? Well, as Jose has shown you in his very nice presentation before, there are many benefits of using whole blood. By the way, this is one of the benefits of having a drone license in the United States, is that you can make pretty cool looking nighttime time lapses with your drone. So I think the main advantage of using whole blood is that it makes the logistics of the resuscitation very easy. You know, when patients go to the Metropolitan Stadium or to Bernabeu, they don't give us the courtesy of putting in an intravenous line in both of their arms just in case their team loses the derby. In fact, when the paramedics arrive on the scene, there is often very limited access to the patient's veins. And when there is limited access, it's nice to have one blood product that provides balanced resuscitation right at the beginning and throughout the whole time that the transfusion is being administered. You know, we've talked in this meeting about balanced resuscitation and why it's so important. And sometimes what I hear from surgeons and anesthesiologists is that at their hospital, they're provided with red cells, plasma, and platelets immediately, and they can transfuse them as quickly as they want in the massive transfusion protocol. But it's not always the case that balanced resuscitation is provided when we're using components. These are some data from our children's hospital, where at our children's hospital, we provide red cells, plasma, and platelets in a pack all at one time. And the surgeons have to remember to use it. And so we ask the question, how long does it take for a patient in trauma to receive 1 unit of plasma, platelets, and red cells? And you can see here, this black line shows the patients who received whole blood. As soon as they started to get whole blood, we stopped the timer because we knew they were getting balanced resuscitation with the whole blood. However, the patients who were receiving components sometimes took hours to receive balanced resuscitation. These patients might have received 5 red cells and 4 plasma, but until they received the platelets, we kept the timer going. And you can see when you don't use whole blood, just how long it takes to provide balanced resuscitation. And we know how important that is early in the resuscitation. Very, very important. So even though the physicians might think that they're giving balanced resuscitation, at least at our children's hospital, where they also thought that, they were not. So whole blood helps. I heard Jose talking about cold stored platelets, so I don't want to spend a lot of time to tell you that we keep the whole blood in the refrigerator, which means the platelets are stored in the cold, and that helps to reduce the risk of bacterial contamination, which is a very big problem with platelets because normally we store them at room temperature. I think another important benefit of whole blood is that it has a much longer storage time than 5 to 7 days for platelets. And so you can imagine a place in Spain that is remote from a hospital or from a blood center, but where tourists go to do outdoor activities, climbing, mountain biking, football. You know, at a small place where the tourists go, you might not be able to store platelets because of the short shelf life. But if you have whole blood, then you'll make platelets available to them when they would not have had the opportunity to receive a platelet transfusion if they have an accident doing tourist things. So whole blood is a way of providing a lot of platelets. You know, in Pittsburgh, we do leukoreduce the whole blood, and we produce about 1/3 of a dose of apheresis platelets in our whole blood. So we do actually have quite a lot of platelets in the whole blood. And of course, cold stored platelets demonstrate in the laboratory improved function over room temperature platelets. This, by the way, is the Bernabeu of Pittsburgh. We call it Highmark Stadium. It holds 5,000 people for football, and sometimes we get 5,000 people. Of course, half of them think that they're going to see the American football. That's a joke. But it is a lot of fun to watch the local team, the Riverhounds, although we're not very good. So, you know, I heard Jose talking about the CHIP study about the children in the cardiac surgery with the cold platelets. And I think that's going to be a very important study to see if things like what we're seeing in the laboratory here matter for patients. This is a laboratory study of platelet aggregation, and the light gray lines here are the cold stored platelets, and you can see that they demonstrate better aggregation than the conventional room temperature platelets. I don't know what this means for the patients. If these better laboratory tests mean that they stop the bleeding better than room temperature platelets or not. But at least from the initial perspective, the initial thought, cold stored platelets look like they perform better than room temperature platelets. But the clinical trials will answer that question for sure. Just like Jose was saying, whole blood is more concentrated or more potent than an equal volume of components. And so here's one way to think about it. Imagine that you're giving a 10-unit massive transfusion to someone. So we're going to give 10 red cells, 10 plasma, and whole blood platelets. If you add up the total volume of the stuff that we have to add to the blood products just to keep it liquid and just to make sure that the red cells have enough food to eat, after 10 units, we've given the patient about 2 liters of this fluid. And this fluid does not transport oxygen. It does not cause blood to clot. It just ends up in their third space and makes it harder to close the wound. So that's a lot of extra fluid. And if we use an unbalanced ratio of 2 red cells, 1 plasma, and 1 platelet, we're still giving almost 1,500 milliliters of fluid that doesn't help the patient. That just ends up in the third space. And if we try this resuscitation with apheresis platelets instead of whole blood platelets, again, because most of this fluid comes from the red cells, we're giving about 1,800 milliliters of this extra fluid. However, if you use whole blood and you give 10 units of whole blood, you're only giving 700 milliliters of this basically saline-like fluid. It's not ideal to be giving saline, but this is the smallest volume that we can give compared to using components. So it's more concentrated and more potent, as Jose said. Also, we know that whole blood is easier to transport. You know, we talked earlier about how little space they have in the helicopters and in the ambulances. So it's nice to be able to bring one product instead of 2 or 3 blood products. Of course, it might reduce donor exposures, which isn't that much of a problem these days. And as Jose, I think, alluded to, whole blood may be a blood-sparing intervention. It might be a patient blood management technique. What do we mean by that? Well, there have been several studies that have looked at the number of red cell units that were transfused after whole blood was administered. And in these first two studies, you can see that patients who received whole blood received about 2 fewer red cell units than patients who received components. And here, these other studies demonstrated a similar finding that overall, patients who get whole blood need fewer components in 6 or 24 hours after the resuscitation began. Now, this is observational data, and there's potential for problems to confound these results. But it's interesting that these data point in the direction that whole blood reduces transfusion. And here we have another study that I know Jose was showing, but this shows that the patients who received component therapy had a volume of 82 milliliters per kilo of blood in 24 hours, whereas the whole blood patients had almost 40% less fluid than the component patients. So it's interesting to think that those cold platelets, that the higher potency, that the earlier administration of the whole blood might lead to reducing the number of components. So then the question becomes, well, is it safe to administer whole blood? And I saw Jose had a very nice graphic about antibodies, but I think you're going to like my graphic better. As Jose said, it's required for us to use group O whole blood because early in the resuscitation, we will not know the patient's ABO blood group, and so we have to use group O red cells. But along with the group O red cells comes group O plasma, which contains anti-A and anti-B antibodies. And so if we end up giving a group O whole blood unit to a patient who is not group O, such as A, B, or AB, then these antibodies could bind to the red cells and cause their destruction. And that red cell destruction is called hemolysis. So to try and reduce the risk, we look for donors who have a low quantity or a low titer of anti-A and anti-B. So let me show you what I mean by hemolysis. Again, I think Jose's figure was very nice, but mine's better. So here we have a unit of group O whole blood, and the group O whole blood has anti-A and anti-B antibodies. If we have a group A recipient and we give them the group O whole blood, then the anti-A could bind to the A red cells and cause them to be destroyed. If we have a group B recipient, you can imagine the anti-B will bind to the antibody to the patient's red cells and destroy it. And in the worst case, if we have a group AB recipient, then you can say that anti-A and anti-B will bind to them and cause their destruction. Now, don't get me wrong, I like Barcelona. I'm sorry to say that, but this is what happens. This is potentially what would happen, is that anti-A and anti-B could bind to the red cells and cause the red cells to lyse. Luckily, when we select units, group O whole blood units that have a low titer of antibody, we don't see evidence of this hemolysis. This antibody destruction of the red cell is theoretical. So here we have patients who received at least 6 units of, at least 4 units of whole blood, many of whom received at least 6 units of whole blood. And we looked at the biochemical markers of hemolysis. And you can see that the patients who were not group O had a little bit higher bilirubin than the group O patients. Don't forget, the group O patients will not hemolyze, but it was still within the normal range. Look at the haptoglobin, very normal. And the LDH was very similar between these two groups of patients. So in adults, we do not see evidence of hemolysis. We looked at the small pediatric patients who weighed 12 kilos, were about 3 years old, and who received quite a large dose of group O whole blood, which was equivalent to about 4 units in an adult. And again, we measured all of the different biochemical parameters, and we did not see any difference. So even in children, even in the smallest children who get a large dose of whole blood, we do not see evidence of hemolysis. So it's very safe to give whole blood to adults and children. And here we just had a new study published in the Thor supplement to Transfusion, where we looked at not injured children. So these were children who were primarily having some type of bleeding from the surgery or gastrointestinal bleeding. And you can see here that there wasn't any difference between the group O patients and the non-group O patients. And don't forget that the non-group O patients were those who could be at risk of having hemolysis. In fact, many of these non-group O patients had better parameters than the group O recipients. So again, this tells us even in children who are not injured in trauma, whole blood is safe to administer. So now that we've demonstrated to you that it's safe to give whole blood from a hemolysis perspective, you're probably wondering, well, how do patients do? What are the outcomes of patients who receive whole blood? Well, here was a very nice meta-analysis that showed that patients who receive whole blood have improved 24-hour survival compared to patients who receive only components. Now, these were all observational studies. None of them were randomized trials. The results of those, including the SWIFT trial, will come later. My prediction is that the SWIFT trial, like the Tower trial, it won't show any difference between whole blood and components. That's just my guess. I don't know any secrets, but judging from the way those two studies were designed, I think that's what we're going to find. Nevertheless, all of these observational data show a benefit to receiving whole blood. In fact, these observational data showed a benefit for the long term, so beyond 24 hours of survival in hospital, 30-day survival. Looks like that's also improved by getting whole blood transfusion in trauma. We did an analysis of some safety measures, like we looked at how long patients spend in the intensive care unit, or the change in their organ function, kidney function, sepsis, that sort of thing. We looked at patients who received only component therapy and those who received whole blood and components. And again, you can see that there isn't any difference in any of these parameters between the component group and the whole blood group. And this is excellent because it tells us once again that getting whole blood is very safe. We did this analysis also in children, and again, you can see even in children, there was not any difference in their outcomes. And in fact, some of the outcomes were better after receiving the whole blood transfusion. So again, safe and effective to use. This was a study that we did where we multi-center study where we looked at patients with a very high probability of dying, And we asked the question, if patients who are highly likely to die receive whole blood, do they have better survival than patients who receive components? And you can see here, both at 4 hours and at 24 hours, that patients with a very high death prediction had better survival if they received whole blood. So even in very severely injured patients, whole blood has a significant benefit at these two relevant time points. We then asked the question, well, if getting a little bit of whole blood is good, what about getting a whole lot of whole blood? And so we analyzed the American trauma database that the level 1 trauma centers are required to report their data. And we looked for adult patients who received at least 10 units of red cells or whole blood in the first 4 hours. And what we found at 4 hours was that there was a trend. Patients who received at least 50% of their total blood volume as whole blood had a trend towards improved survival. But at 24 hours, it was clear that the more whole blood that patients received, the larger the proportion of whole blood compared to the total blood volume that they received, there was an improvement in survival. So if you're going to give whole blood, give a lot of it, because it appears that giving a lot of whole blood helps to improve survival. But don't just take our word for it. Another group did a similar analysis where they looked at adult patients who received a smaller volume of whole blood, and they found that compared to component therapy alone, there was a 13% decrease in 4-hour mortality for every 10% increase in the whole blood to total transfusion volume ratio. So as you were giving more whole blood, there was a 13% decrease in mortality as the amount of whole blood increased. And interestingly, they found, just like in our study, that the critical threshold is about 30%. So what you really want to aim for is a 30% whole blood to blood volume ratio. That's when we start to see the benefits the most. We found the same thing in children. So we went back to the National Trauma Database, and we looked at pediatric patients who received any whole blood. And what we found was that the patients who received at least 30% whole blood, so at least 30% of all the blood that they received in 4 hours, when that was whole blood, they had significantly improved 6-hour, 12-hour, and 24-hour survival compared to patients who received less whole blood. So in children, it's very clear that the best survival comes when they get at least 30% whole blood. So if you're going to give whole blood, give a lot. And wouldn't you know it, another group also did the same analysis of pediatric trauma patients. And again, what they found in their analysis was there was a 9% decrease in 24-hour mortality every time the patient's whole blood transfusion volume went up by 10%. So all of these studies are pointing in the same direction, which means they're either all confounded in the same way, or they've all come to the truth, which is that for patients to have a benefit from whole blood, they need to get a lot of whole blood. So now for a little bit of philosophy. Why is it that whole blood saves more lives than components? And I think obviously whole blood by itself has some advantages, but as the colleague earlier today was talking about some of the limitations of the trial, you know, giving 1 or 2 units of plasma and thinking that at 30 days that's going to have an impact is it's a bit difficult to imagine that could actually be the case, that those 1 or 2 units of whole blood that you gave right at the beginning would have an impact later in the patient's course. So I think whole blood does have an important impact early, 4 hours and 6-hour mortality. But I think if you're receiving whole blood, then you're probably also at a hospital or in a region that is really on the um, on the cutting edge, that it keeps up with the literature, that follows the literature, that is pushing the limits of their transfusions and their trauma care. Just like Jose said, you know, the way we've done it is the best way. That is the worst thing to say. If you're getting whole blood, you're at an institution that says, what is the new thing? What is the evidence-based thing? Let's implement that. You know, let's resuscitate patients before we put a tube down their throat and make it worse. Let's be rational about who gets tranexamic acid. No more crystalloid. And let's implement pre-hospital transfusions. So I think whole blood by itself has benefits in the short term, but I think the system in which the whole blood is being administered is largely responsible for why patients have better outcomes. Whole blood is a marker for an advanced trauma system, I think. And here's a slide for Chris showing what the Norwegians would consider sunset. It doesn't really go all the way down, does it, at this time of the year in Norway? And that's great because it means that you can have a fun day and it never really ends in Bergen. And so let's ask the question, who is using whole blood? This is a graph of the level 1 trauma centers in the United States that are using whole blood. That's the black bars here, and you can see the black bars start to go up after 2018 because this is when we convinced our regulator to change the whole blood standard and let us use whole blood for patients of any blood type. In fact, more than half of the centers that we surveyed were using Rh positive whole blood for women of childbearing potential, which is another topic by itself. But again, it shows that if you're getting whole blood, you're at a center that understands the low risk of hemolytic disease of the fetus and newborn and understands the benefit of using whole blood, even if it's Rh positive for women. And I fully agree with the comment that even if whole blood isn't shown to be better in a study, if it makes the lives of the paramedics and the surgeons and the anesthesiologists easier, if it helps them to provide balanced resuscitation and they find it more convenient, that alone is a good reason to use whole blood. If we get data from the trials that show that it works, that's great, but making their life easier, I think, is an important end by itself. Interestingly, the most recent data that we have from 2022 shows that almost 300 American level 1 trauma centers are using whole blood, and that includes 33 pediatric centers as well. So whole blood is very much becoming the product to use for resuscitation. It's not the standard of care yet, I don't think, but it's becoming much more commonly used. So that's the United States. But if you look around the world, you know, the Israelis, after October 7, can't get enough of whole blood. It took me years to convince them to use whole blood, and now they're all over. They use whole blood quite a lot. Our excellent colleagues in Brazil, from whom we heard earlier today, Daisa, is probably in the most advanced aeromedical service in Brazil, in Santa Catarina. They've been using whole blood for several years, and they were gracious enough to give me a ride in the helicopter and hold the whole blood when I visited. Obrigado, that was great. Norwegians were super early adopters of whole blood and have been showing the rest of the world how safe and effective it is for a long time. The Estonians started using whole blood, they like it. Czech Republic, Jose and Spain are using whole blood, and Finland have it on their EMS. And there are other countries like UK, Canada, Australia that are on the way to using whole blood. So you're not alone. Many other countries are using whole blood. So in conclusion then, whole blood has many advantages over component therapy, and we know it's safe to use. The initial studies showing the efficacy and survival advantage are observational studies. They're limited, but we'll start to get some data from randomized trials. Maybe I should put months here instead of years. What's interesting in the United States is I don't know of any hospital that started using whole blood and then stopped it because they didn't like it. There were some hospitals that transfused 1 or 2 units per year and then stopped. And I think that's fine because they weren't using it very much. But I haven't heard of any trauma center that has started to use it and then said, we don't like it, stop. And I think all of the logistical issues with whole blood, with titers, with RH, they've all been solved and overcome. And so if you're having some trouble or if you come up to an obstacle, somebody in the world has solved the problem, and we would be happy to help you. Lastly, I want to leave you not with a picture of what plus 35 Celsius looks like, but with a picture of what minus 10 Celsius looks like when the rivers get so cold that they freeze. So, muchas gracias again for the wonderful invitation to speak at this important meeting. And if Jose didn't answer all the questions before, I'm happy to take some now. Thank you.
Thank you very much. Lovely speak. Thank you, Mark. It's been amazing listening to you, and I would like to pass the questions. Any question here? Any
More comments about my Fernando Alonso shirt, which I thought you would all like.
And I would like to get your opinion about fibrinogen and calcium as well. So we were talking with Jose. I asked Jose the question I would like to know was your opinion about. So once you start with whole blood, what is happening with fibrinogen and what's happening with calcium?
Well, I mean, I think you've hit on some very important and controversial topics. Fibrinogen is an issue for some patients who have a hyperfibrinolytic picture. I think those patients can be adequately treated in the hospital with either a fibrinogen concentrate or with a cryoprecipitate once we've identified who those 20% of the patients are, or better yet, if you're dealing with one of those 20% of patients who becomes hyperfibrinolytic. I think in the pre-hospital setting with short transport times, getting whole blood that gives the balanced resuscitation to the patient is the most important thing to do. Even if you have a 1-hour transport time, that's plenty of time to transfuse 2 units of whole blood if the patient needs it. And when they get to the hospital and they do the testing, then we can see if we need something to raise the fibrinogen more than what was already given in the whole blood. I think calcium is another extremely important issue. And I think we need to first understand why some patients have low calcium in trauma. Is it because of the trauma? Is it because of the transfusion? Or is it a combination of the two? And the question then becomes, do we need to correct it and how best to correct it? And I think that we still don't have the full understanding of the mechanism or the ideal way to approach patients with hypocalcemia. Surely it's not a good thing to be hypocalcemic, but the question becomes, should we give everybody some calcium? And I think from some of the data that we saw this year at the Thor meeting in Norway, that not all patients will benefit from it, and there could be some harm to some of the recipients. And so I think what we need is a more test-based approach to see who will benefit from fibrinogen and who will benefit from calcium supplementation. I can't hear Ricardo.
Okay. So last question is, as I understood, it will work. So at the very beginning, with a patient in hemorrhagic shock that is going to need a massive transfusion, you can use whole blood, and then once you arrive to the hospital, you do the thromboelastography and you change to components. So this is
Yes.
the way it works.
We do this, you know, and it's difficult to know at what point to switch from whole blood to components. I think that given the experience in the room there, that you simply will know when the time is right. You'll know when the patient's bleeding rate has come down. You'll know when they're stabilizing, and the thromboelastic test will help to guide you to that point. I don't think that whole blood is necessarily the best product to use for the entire resuscitation. I think it's the best product to use until we understand the patient's hemoglobin and coagulation situation. And then once we understand if the patient is deficient in those products, we can provide the specific product that they need to reverse that problem. But when you have a patient who's just bleeding and bleeding, you can test all you want, and it's not going to matter because they're just bleeding. The testing isn't going to help guide the resuscitation. You need to put a stitch in. That's what the patient needs. And in those patients, lots of whole blood is the ideal solution because you're replacing exactly what they're bleeding. And then once the bleeding comes under control, you can then decide if you really need more red cells or plasma. So I think whole blood is really good at the beginning when we don't have control and when we don't have information on the patient.
Yeah. Hi, Mark. Christopher from Norway here. Thank you for the picture. I totally agree with your last comment, right? And that's the way we do it. Whole blood is for the pre-surgical phase, and then once you have hemorrhage control, then you can switch to goal-directed therapy or whatnot. But since we have you here, can you, because I know that you have done some risk-benefit calculations on HFDN, rhesus alloimmunization. Can you just touch into that? Because I think it's interesting.
Yeah, for sure. So briefly, the problem is that if you have an RHD negative, or some people call it rhesus, if you have an RHD negative woman who's before age 49 or 50, and you give her an RH positive unit of whole blood or red cells, there's a 20 to 30% chance that she could make an antibody to that D, like delta antigen. And if she makes that antibody and she gets pregnant again in the future with a baby that is D positive, that antibody can go into the baby and destroy the baby's red cells, and the baby could die. And that disease is called hemolytic disease of the fetus and newborn. And so we would really like to give RHD negative products to women of childbearing potential. That is, women from age 0 to age 49. But we don't have enough RHD negative products. And so we've done some calculations. Excuse me. We've done some calculations to show that the risk of the woman having a fetus die, the risk of her baby dying from the antibody after she gets a D positive transfusion is less than 1%. And that assumes that the woman has access to modern healthcare, like she has access to people who can do an intrauterine transfusion and who can do appropriate monitoring. And that's the worst case. About 1% of patients of women will have a baby who dies. And if you consider other less severe cases of hemolytic disease of the fetus and newborn, that's about 6%. So up to about 6% of women might have a less severe outcome from hemolytic disease of the fetus and newborn. But you have to put that in perspective of the benefit that pre-hospital transfusion gives. You know, even in the refill study, which my opinion is that the outcome of that study, the primary outcome, was inappropriate because it was it was episode mortality, and it was basically 8-day mortality, not short-term mortality. But if you look at the 3-hour mortality rate in that study, there was like a 25% absolute risk reduction for pre-hospital transfusion. So we're comparing 1% or 6% of a risk to a future baby to almost a 25% reduction in mortality by giving a pre-hospital transfusion. So I think that the scale is very much in the way of giving the transfusion. And in fact, we've done a lot of surveys. We've asked women, what would you rather have? Like, would you take a transfusion that would improve your chances of living, but it might cause harm to a future baby? And the overwhelming majority of these women would absolutely take the chance of living against the chance of a future pregnancy. So it's a very complex topic that I've summarized in 2 minutes. But the real message here is never ever hesitate to give a D positive transfusion to a woman, because if she needs that transfusion, the benefit of saving her life far exceeds the risk to a future pregnancy.
So we have a question, an online question from Javier. He asked, are you using thromboelastography in hospital after using whole blood in the street? What are the results if you have an experience of it?
Yeah, that's a good question. Our answer is yes. Thromboelastography is an important part of our resuscitation protocol. And I think Randy really said it the best at her institution, where they see patients with lower base deficits and better coagulation parameters after receiving whole blood than patients who didn't get it. We haven't formally studied it, but surely that will be an outcome of these randomized trials, where they'll look at the actually we did a pilot study. So the UK is doing the SWIFT study, and we're doing a similar study here that's called Tower, and our study is almost finished as well. And we did a pilot study of like 100 patients, very small pilot study, and we actually found improved thromboelastography parameters, in particular the platelet function, amongst patients who received pre-hospital whole blood compared to components. And this should be pretty obvious because we don't use platelets in the pre-hospital phase. So the patients obviously had better platelet function because we gave them cold stored functional platelets. So I think there are benefits to be seen, and the randomized trials will sure show us better data.
Any other questions? Okay, I would like to thank you, Mark, because you've been so approachable, so kind with us. Thank you again for your availability, for your speech. Okay.
And congratulations on a successful meeting. Really well done.